University rounds. I'd like to welcome everyone who's come here in person today to the Hollywood Theatre. It's a kids, and also welcome all of you who have joined us online. It's a very special university rounds today because it's a joint presentation between the Department of Surgery and the Department of Obstetrics and Gynaecology at the University of Toronto. And in recognition of that, our land acknowledgement is going to be given by the chair of OBGYN, who is Kelly Murphy, and I'm very happy to welcome Kelly here today.
Good morning, and thanks everybody for joining us in person and for those of you online. We want to acknowledge the land on which Temerty Faculty of Medicine operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the New Credit River. Today, this is the meeting place, is still home to many Indigenous people from Turtle Island, and we are grateful to have the opportunity to work and live on this land. Through my own work, I hope to improve the health and well-being of Indigenous people, and I offer that privilege and opportunity for you all.
Thanks very much, Kelly. Just by way of a little bit of background about the topic for today, in June of 2023, we had a strategic retreat in the Department of Surgery, and we focused on three hot button issues, one of which was renewal of our practice plans. You may not realize there are 32 different practice plans in the Department of Surgery. Most of them were developed in the 1980s, and the majority hadn't been updated since that time. And a lot of things have changed. One of the main things that have changed is a number of people who are becoming parents as surgical residents, fellows, or young faculty, and require some kind of acknowledgement of that in terms of what's in the practice plan. Another aspect of parenting and surgery, of course, is some of the conflicts that arise due to clashes in roles and just feasibility and timing and teamwork. All of these can be challenges, and we recognize that our colleagues in OBGYN were also very interested in this topic and have done a substantial amount of work to gather evidence and develop consensus. So that's the genesis for the combined rounds today. After the strategic retreat, I asked Terry Axelrod and Danielle Bischof to lead a working group on this topic of practice plan renewal within the Department of Surgery. And they're going to talk a bit about their working group's progress and conclusions today. So I'm going to welcome Danielle Bischof, who's a surgical oncologist at Mount Sinai, Terry Axelrod, who is the lead for the biggest practice plan in the city, in the Department of Surgery. That's the orthopedics group at Sunnybrook. So they'll give a joint presentation now. Thanks, Danielle. Oh,
Has some introduction.
sorry, that is not correct. Andrea Simpson, who's from OBGYN and works at St. Mike's, is going to kick off with an introduction.
Thank you so much. Thanks for everyone attending today. So a little bit of background of why we're talking about this. So parenthood during a medical career is unfortunately still regarded largely as an inconvenience. So this is some data from the National Physician Health Survey of 2021. So CMA surveyed over 4,000 physicians. And if we had to kind of summarize this data in a couple words, the parents are not thriving. So parents reported the lowest rates of flourishing mental health at 41%. And low professional fulfillment as well. We know that parents in medicine face a lot of challenges: lack of accommodation for childcare challenges, lack of career advancement, sometimes exclusion from job or training opportunities, negative referral patterns when they return from a leave, and resentment from colleagues for the extra workload that others may experience when a physician goes on leave, and sometimes resentment from our patients as well. So what are the consequences for individual physicians? So this is some Ontario data. Since it's so hard to become a physician parent, physicians often delay childbearing until later ages. For surgical specialties in particular, women surgeons are more likely than male surgeons to remain childless and experience gender-based discrimination related to parenting. And they're also more likely to leave surgical training, unfortunately. We continue to place the onus on the individuals to succeed in a system that has historically excluded women and has only recently begun to acknowledge the importance of physician wellness. This is Ontario data showing that physicians are less likely than non-physicians to have children at younger ages. Around the age of 37, the cumulative probability of childbirth actually for physicians exceeds non-physicians, suggesting that physicians were always planning to have children, but were intentionally delaying to later maternal ages. We also looked at pregnancy outcomes among physicians compared to non-physicians, and physicians do experience worse pregnancy outcomes, but when you adjust for age, a lot of these differences actually disappear, suggesting that they're largely driven by advanced maternal age. So after delivery, parental leave and accommodations for parents remain a challenge. So paid parental leave is an important health accommodation with many potential benefits, including longer duration of breastfeeding. And although progress has been made in some areas, so PARO has benefits for residents now and rules around call for residents who are pregnant. Workload reductions for practicing physicians are not always available. So again, looking in Ontario, we actually observed an increase in workload in the first 2 trimesters of pregnancy among pregnant physicians, with then a reduction in the 3rd trimester. Potential reasons for this is that they may be preparing for loss of income during their leave, or they're within a call group system where they're required to sort of pay it forward before going on leave. After delivery, the average parental leave among Ontario physician mothers is 4.5 to 5.5 months. By comparison, less than 10% of Canadians who receive parental leave pay return to the workforce before 8 months. So again, what are the barriers to taking a longer leave? Well, lack of coverage is a big one, finding someone to cover your practice, concerns about burdening colleagues or losing referral networks, loss of income, typically at a time when early career physicians have substantial loans to repay from their medical training. So I'm going to turn it over now to Terry and Danielle.
Great. Can everybody hear me?
Yes.
Great, thanks. Good morning. Danielle, thank you very much for doing the slide advancement for me. Good morning to everybody. I apologize, but don't apologize, but I'm out there in person, but I'm happy to be a part of this production. So we'll go to the next slide. As Carol said, the Department of Surgery practice plan situation was quite outdated, and we have been struggling with this for quite a few years, pretty much since I started on staff, which would have been around 1989, 1990. We've been having problems with the practice plan, with compliance, and so on. So just a little bit of the background information. Within our department, as Carol mentioned, we have multiple divisions with independent and very varied practice arrangements. It's a little different than the Department of Obstetrics and Gynaecology. We have about 32 groups. Each one of these are separate financial units, and they usually have a leader within them. Some of them are division-based in the hospital, others are department-based. As I understand, for example, at Sinai, it's department-based, whereas at Sunnybrook, it's division-based. Next slide. My history with this goes back a long way because various chairs of the Department of Surgery have struggled with this, with the problems of the practice plans. I mean, it goes back to the days of Dr. Bernie Langer, and then Richard Resnick, and then Jim Rutka, and now Carol has, it's fallen on Carol's lap to do something about this. So the problems have been to create practice plans, the documents that can be compliant with the university requirements. But these have to be inclusive and create models that would serve all of the 32 divisions of financial units. The next issue is, how do you ensure compliance with the models once the department has said this is what you should do? And the plans that have been in place in the past were not flexible nor adaptable. And those people overseeing the plans were not particularly flexible or adaptable. So we had to move forward. Next slide, please. So back in the days of Dr. Resnick, which is 3 generations back, lawyers and accountants were contracted to create the different models of practice plans within our department. And there was 3 practice plan models. There was the so-called equal sharing model, where everybody's income from all sources was pooled, everybody shared expenses, and everybody took home basically the same amount of money. So that was the communist model. There was the gross income model, which was basically everybody could run their own practices, their own divisional practice plans, but a certain amount of gross income got set aside for sharing and a certain percentage for academic enrichment funds. Net income was similar to gross, it was just in the fine details from which they were different. But each document was written in legal terms and spanned about 25 pages. They were very complex and very hard to follow. And a senior administrative person in the department was assigned to oversee compliance, and that was Nancy Kondo. And that didn't always work out so well. Next page. So the conflicts were common and compliance was very, very low with this. So Jim Rutka, when he was chair, asked me to look into this because I think he respected our practice plan at Sunnybrook, which seemed to be working, even though it was different than one of those 3 models. So I sent around a confidential survey to all of the financial unit managers within the department, and I found out the following, that out of, say, 32 financial units, only 3 or 4 were fully compliant, and those were mostly the group shared plans. 10 were partially compliant, by partially anywhere from, just a little bit to, a little bit more than a little bit. And the rest were really just in the spirit or ignored the practice plans completely. So next page. So what was the problem with the practice plans? Well, they were too complex and non-flexible. And, if you're talking to a bunch of surgeons about money, we don't really like the idea of top-down or dictatorial directions being given from above. What could work for a group of 20 surgeons may not work for a group of 3 or 4, and there was no option to modify these. And then the key was there was no way to really update these plans. They didn't allow for adequate provisions for parental leave, for illness, and sabbatical. Next. So we had to move on. So what did we do? As Carol mentioned when she introduced us this morning, she asked us to strike a working group through the retreat to come up with a new concept for practice plans. And Danielle and myself put together several group sessions to work on concept development, and then from that, of course, maturation and refinement. We worked on the idea that we wanted principles for practice plans rather than rules. And I think it's on to you, Danielle.
We really recognized in our focus groups that there's really a need for individualization of practice plans to suit the individual circumstances of each group. How big the group is, sources of income are important for practice plans. And then the third one, the Department of Surgery does not want to dictate the terms of or micromanage these practice plans, and rather is asking for conformity to the principles that will follow. So in terms of principles, so the practice plans must conform to the guidelines as directed by Temerity Faculty of Medicine. Temerity Faculty of Medicine has a set of guidelines for practice plans, and we've incorporated that into our principles here. The manager of the practice plan must report compliance annually to the chair of the Department of Surgery. All members of the practice plan must conform agreement to the terms of the practice plan by signing the document. The conforming academic practice plan must have a well understood, transparent, and equitable decision-making mechanism for allocating resources to individual plan members. Within the practice plan, there must be a separate academic enrichment fund that provides a pooled source of funds for the members of the plan to use to support the academic mission of the Department of Surgery. Contributions to the AEF would normally be sourced as a percentage of the individual surgeon's income. However, additional sources of revenue may be used to contribute to this fund. Additional sources being grants, foundation money, that type of thing. Accounting of the AEF should be available to all members of the practice plan yearly and upon request. And then this is, I think, the meat of the principles, and this is why we're here talking about it today at this session about parental leave. So all practice plans must have a provision for parental leave. Support for parental leave may come from individual practice plan associates or in combination with the hospital or university department of surgery. Fluidity is needed here as hospital departments, the OMA and Ministry of Health have developed and are continuing to update parental leave opportunities. Recommended duration of support is a minimum of 3 months for parental leave, with an obligation, like the longest obligation being 12 months. Similarly, all practice plans should have a provision for sabbatical leave. The terms of such a leave will be delegated to individual practice plans to define. Sabbatical leave may be self-funded, may be funded by the practice plan or by outside sources. Duration of support for sabbatical leave was a 6-week minimum with a 12-month maximum. And finally, all practice plans must have a provision for medical leave, including caregiver or bereavement leave. The terms of such a leave would be for individual practice plans to define. And then the final principle, final point, all practice plans must have a dispute resolution process, and this is a requirement by Temerity Faculty of Medicine. Okay.
Thank you very much, Danielle and Terry. And I guess this is Sharon next. Is that correct? Okay. We're going to save questions and discussion to the end. I'm sure there are already a few things that have come up in your minds. So Sharon Dason is with the Department of OBGYN. She works at Trio Fertility. And she was a fellow when we first started this work. She's done a huge amount of work to develop consensus within both of our departments, and she's going to present some of the results of that process today. Thanks, Sharon.
Thanks so much. I'm super excited to be here. This has been kind of 2 years in the making for me. Oh, did I lose my slides? There we go. Sorry. Okay, perfect. So I'm going to talk a little bit about what we did within the two departments to kind of create a consensus or to bring up this issue and talk about it amongst everyone. My work actually started with medical students and residents and fellows, and then the staff started to say, we want to be included in this too. And so we've progressed to include everyone. And so I'm going to talk a little bit about that. So we performed a needs assessment first within the departments of surgery and obstetrics and gynecology. And the first thing that we did was approach Dr. Swallow and Dr. Murphy, who both felt that this was an important topic. And we were given the opportunity to present at faculty development days for both departments. And we facilitated focus groups or small group discussions about how we could improve support for surgeon parents or people who are considering starting their family planning. And then we also conducted individual interviews with members of both departments and conducted a survey through the departments, which you may have seen come around. And then we used all of that information that we gained from all of the members of the departments to facilitate discussions within the leaders, within both departments at a joint leadership meeting. And we actually had two wonderful qualitative researchers come and help us to summarize the meeting and to try to get all of that information into a best practices document that could help the departments figure out how to support their members. So when we did the survey, this is just an example of how people felt about the perception of support within each department. And so there were some people that felt well supported, but there was also a good number of people that didn't feel well supported within the department. And that was kind of what we were trying to elicit within these discussions. And these are some quotes, which I'd like to leave on the screen. I tried to include a lot of quotes just because I wanted to show you, reflect back to you what people in the department were saying. But one of the things that came up was this concept of trying to recruit people and the benefits potentially of initiating some sort of policy change to support young physicians. And some of the things that came up was it will help us with recruitment, it will help us with retention and fulfillment for those later in their careers, and it'll avoid resentment and regret. Okay, I'll just leave that there for a moment. I know it's a bit small on the screen, but maybe read the bolded parts because I think those are the ones that are important. Okay, I'm going to flip to my next slide here. These were some of the supports that people said they would desire within the department. So flexibility and time off, more financial leave support, help finding coverage, childcare support, and more connection with mentors. This was present in both departments as priorities. And so what we came up with was 4 main foci that we wanted to focus on. And so one is pregnancy, breastfeeding, and return to work. How do we support physicians doing that? Parental leave support, which is the focus of today's meeting. Departmental meetings was a big one that came up in our discussions as well, and academic progression. So those are things where we kind of focused our document on. I'm going to go through each one. So the first one, pregnancy, breastfeeding, and return to work. These were things that were highlighted, things like occupational hazards that people were concerned about. We recommended things like alternative work models or people thinking about that within their department, especially those who need to work part-time due to pregnancy-related complications. We just heard from Dr. Simpson about how people will increase work in first and second trimester of their pregnancy in order to accommodate going on leave. And for whatever reason, that may not be beneficial for people, especially if they're struggling with health complications. So thinking about how we can support our colleagues in that way. We also thought about opt-out policies for overnight call duties after 28 weeks and opt-out policies for reduced OR time. And when I use the term opt-out, that's because people may choose to opt in and still continue to work depending on how they want to supplement their income. But we wanted to support people in being able to say that they need that time off in order to focus on their health. And the other thing that came up was this concept of payback policies. I think that's been a concern as well, especially when people are going off of work from maternity leave or for parental leave. And the other big thing that came up, which we're hoping will be an action item for most hospitals, is an accessible breastfeeding space that's close to operating rooms. So that was often one of the concerns, that the breastfeeding space is really far away and people have to map out their time to get there when they're actually operating, which can be challenging for people, especially when they're returning to work after 4 or 5 months, as we saw before, and possibly less. We also suggested that it would be helpful to implement a meeting with a department, division, or hospital leader prior to leave and upon return to discuss all these things, to have a protected space to bring things up, and to talk about pregnancy accommodations, duration of time away, locum coverage, research grants, and supervisory transition, which is important for academic physicians, of course, and that transition back to work. So there's that space to talk about those things. This is just one of the quotes that came up. A lot of people talked about kind of difficulty breastfeeding as well when you're returning to work early. Parental leave support, as I said, it's so wonderful to highlight the people in the Department of Surgery who have been working on this. And what we talked about is having an explicit description of parental leave support in all contracts, thinking about financial support as suggested in the practice plan document, tailored solutions, transparent funding, administrative help with the PBLBP applications, which are very difficult for people as well, and can be complicated when you're trying to go through all of those terms, and you have a newborn screaming at you as well. And a minimum of 12 weeks of support, okay? These are also some quotes from our departments of people sharing, just encouraging parental leaves, people who have to take shorter parental leaves or who are encouraged to take shorter parental leaves, maybe against what they wanted to do, okay? Another big quote here. Just this talk about how it can be difficult for people to actually approach their leaders. And so thinking about setting up those meetings, making it a standard that those meetings are just part of our culture, okay? And not something that people have to request to talk about a little bit more. Okay, these are some worldwide recommendations that I wanted to share with you. UNICEF says 18 weeks minimum for maternity leaves and 6 months suggested for parental leave. And WHO says exclusive breastfeeding for 6 months and up to 2 years of a child's life. So these things are things that are important worldwide and things that we should really think about in supporting our colleagues as well. The third point was about departmental meetings. So this was actually a really big topic and it was very challenging. And today, actually, we have a lot of people in person, but I think we have like 180 people who have joined virtually, 204 people who have joined virtually. So just kind of highlighting some of the strategies to improve attendance at meetings here. But one of the things is flexible meeting strategies. So rotating times, virtual or hybrid options, which we have today, alternative communication for information dissemination. So recorded meetings, today's meeting is recorded, email updates, opportunities for survey responses, and shorter meeting durations with tight agendas so people are able to get back to their daily lives. I have a ton of quotes about meetings, surprisingly, but these are some of them just to highlight to you how important it is to people, because all of us want to be engaged in our department, but it can be hard when we have multiple meetings a week and we're balancing things at home as well. This one's long, but read the highlighted version. It's important to people. It may seem small, but it's an important point for people to have engagement in these meetings and how we can improve that. Okay. Now, the fourth one is obviously a bit of a lofty goal, but this concept about academic progression. So there were 4 points that came up here. One is thinking about flexible policies to accommodate individuals and to provide equitable opportunities, to think about reevaluating our evaluation criteria, to provide support for career reconnection for those people who are going on leave and coming back, and to continue to promote collaboration and engagement. So these are some of the quotes that came up here, and some of the points about how things like applying for grants aren't provided with points, or this concept that there's a lot of work that goes in that isn't necessarily always recognized. And there's also this pressure to be productive within those first 2 to 3 years in practice. And I myself am about 9 months into practice and I'm slightly overwhelmed sometimes. So I can understand that feeling of also feeling like there's another pressure on top of that. Here's another quote just of people feeling like they were behind in those first few years, not really sure how to kind of improve that and how we can support our starting positions, especially as we think about that concept of recruitment and retention and fulfillment in academic positions. Here's another one. Okay, so this one I wanted to put up because this is the end of my little part, and then I will be handing it over to Dr. Wright, who's going to be talking about how she actually implemented a policy at Sunnybrook, which is amazing. But I wanted to just put this up here because it's a really important quote just about how invested is the department, faculty, and university in this, because is this a bait and switch situation where one of the worst things is to be asked your opinion and then have it not acted in any meaningful way? Okay, some document or some light item policy on paper doesn't really mean much. I think there's a culture such that people, for the most part, aren't even going to ask for the things that they're entitled to. So changing what people are entitled to on paper is not really that meaningful in my perspective. And I wanted to show this because that's part of the impetus for these rounds, to show you that both departments are serious about this, to show you that there are practice plan changes in place, and now to introduce Dr. Wright, who is going to tell us how she's implemented this at Sunnybrook itself.
Thanks so much, Sharon. That is really, I've seen most of the material before, but it's quite, I guess, almost shocking to see some of those quotes and to realize that they all come from, 2 or 3 years time span, not 20 years ago. So yes, a need for culture change, and how do we get to the point where there is an alteration in the culture, not just what's on paper? And so Dr. Wright, who's the Surgeon-in-Chief at Sunnybrook, is going to tell us the magic.
Thanks, everyone. Thanks to everyone in the room and online as well. So I'm going to speak a little bit about our Department of Surgery parental leave policy. This is the first iteration of this policy, so things may change as more people go through parental leave. And before I start, I really want to give a shout out to Najma Ahmed at Unity Health. She shared her parental leave policy with me, and our policy is based on Najma's policy. So she put in a lot of the work in the beginning, which is great. So our policy came into effect on April of 2024. We had very strong Department of Surgery support for this policy, and a lot of input from the group, which was fantastic. We all felt it was very important to support our surgical faculty while they were on parental leave, and to really clearly define what the clinical and teaching expectations were, i.e. none, while you were on parental leave. So who does our parental leave policy apply to? So it applies to all parents, those giving birth or otherwise. It also includes parents who become parents via adoption or surrogacy, and also birth mothers who experience stillbirth after 23 weeks of gestation. So we tried to keep it, and the department felt very strongly that this should be quite broad. So our parameters of the parental leave policy, it's for a maximum of 12 weeks. I would note that AFP funds that flow to academic health centers do carry on for a year if you're on, to a maximum of a year if you're on parental leave. And also there are OMA benefits as well, although they're quite strict and you really need to look at them quite carefully and how everything fits together financially. Our parental leave was meant to be taken within a year of becoming a parent, and we specified that no teaching, and you shouldn't have to do all your teaching beforehand, and really minimal clinical work, if any, remembering that the clinical work, as we'll talk about, can get clawed back, or the income you make while you're doing the clinical work can get clawed back from the OMA parental leave policy. So for us, as I mentioned, the AFP funds can continue during parental leave for a maximum of 12 months. If you're going to get funds from Sunnybrook, then you need to also participate in the OMA pregnancy and parental leave policy. That program gives you up to $1,300 per week for 17 weeks. You cannot have more than $1,300 per week in clinical income, which includes AFP if you're on the OMA program. Otherwise, they claw it back. So if you have $1,400 worth of billings, then that's $100 more than you're meant to make on the OMA. So the OMA will give you $1,200 that week, not $1,300. So you really have to look very, very carefully at the OMA program. So our policy, we give out $1,300 for 12 weeks. The person who's taken it so far took that as a lump sum. Those funds come from partially from the department or the chief of surgery, and they come partially for the division, and I'll show you the breakdown for that. We ask that the faculty taking parental leave tells us when they want that fund. We had initially suggested that be done after the OMA program's finished, but when you look at the fine print of the OMA program, it actually doesn't matter. So this is, I think you guys can read this, but essentially what this shows is depending on the size of your department or division, will depend on where the money comes from. So if it's a small division, up to 9 people, then the surgeon in chief funds 60% of the income that goes to the faculty, and the division pays the 40%. If you're more than 16 people, then the division pays 60 and I pay 40. If it's in between, it's 50-50. People asked, where do the funds come from? So I have a budget as being surgeon in chief. I can also use foundation funds, and I checked this with the hospital. As long as those foundation funds include terms of reference like surgeon wellness, recruitment, etc., And this also applies to the divisions as well. So if they have foundation funds that they want to use, just look at the terms of reference and make sure that it fits. So what's happened since April of 2024? We've had one surgeon take parental leave. That person did not take extra call prior to leave, but they did have a locum. The locum is covering their clinical practice. The support was requested after the OMA support was finished. And then, as I mentioned, this is kind of the first iteration of this policy, and we'll kind of adjust it as people go through the parental leave. One of the things that this talk actually sparked was conversations about opting out for call. We brought that up at our last department meeting, and really a big split. Like, there's a lot of financial need for people. People don't want to be told to stop doing call because they may need the income, especially if they're going to be off on parental leave. But then we also want to make it available to people to stop call if they want to, because being pregnant in your doing call in your third trimester isn't the greatest. So really, this is the beginning of our policy, and we'll adjust it as we go along. That's it.
Right. Thank you, Francis. And I think for the discussion and questions, we're going to be a little bit fluid in terms of who are you directing your question or your comment to. Do we have some online already? Nothing yet. So maybe if you have something that you want to mention, you can say, is it a general comment or is there a specific person that you want to have asked, and we'll get them to handle your question. So in person, do we have anybody who would like to make a comment? Yeah. Yeah. I think that's Selena, right? Yeah. Oh, I don't think it's working, is it?
Oh God. Hi, I'm Selena. I'm one of the ortho trainees, and I'm on a pregnancy and orthopedics working group. So it was more of a comment just to really express some gratitude for the work that you guys presented today. One of the things that I think is really critical from my perspective as a trainee who's been pregnant is that the tone is really set by leadership. And so I've had a lot of really mixed experiences with pregnancy and childbearing throughout my training. And I think that part of that comes from a lack of support to the actual surgeons when they were going through analogous situations. So I think that that's really critical. I guess I don't have the perspective of understanding the burden of having a financial pressure to keep working while pregnant. So my perspective has primarily been that I wanted protections while I was even in my first trimester. I know everyone talks a lot about the third trimester, but I, for example, was quite ill in my first trimester, and I found it very challenging with my clinical duties, and there was no process to follow, or at least no accepted process. So, I mean, I guess my question would be like, what are some of the barriers towards the culture change, the implementation? Because from my perspective, in my department, this feels very far away from where we are culturally, like the perspectives. When I went to clinic and told my preceptor that I was pregnant, like he didn't say congratulations. He just looked at me and said, "Are you coming to work? Like, are you telling me that you're not coming back?" So I think that changing that perspective and shifting that narrative is critical. I don't know what actual process implementation strategy you guys talk about for actually disseminating for culture.
Very important question. So Francis, I think we see a lot of heterogeneity between hospitals, between divisions, between groups. How are you trying to make this a little bit more of a general culture shift? What do you have any recommendations for those who are struggling? Go ahead.
I think the main thing is discussing it on a fairly regular basis. It's been we've discussed it as a group at our department meetings. Our policy was circulated, got lots of feedback from people, and hopefully they feel comfortable emailing or talking to me or texting, and I certainly got lots of good feedback about it. With regards to the opting out of pregnancy, Laura Snell is actually going to do a survey of the female surgeons at our place so that everyone can give their input. I think normalizing pregnancy, it sounds funny, doesn't it? But normalizing it as a normal part of work and quite frankly, parental leave as well, normalizing that for both males and females is really one way just to get around this, I think.
Erin, do you have an answer?
No. I just wanted to add on to Selena's point that I think that, once we have these policies, we could probably go to the Royal College, because a lot of the barriers are around, you're only allowed to take 3 months off, and then you have to make up your whole year, and you can't have a rolling exam. The exams are only in June. So, if your leave doesn't sort of line up with your exam, like you have to wait another year. And, the funding for your residency isn't necessarily going to last an extra year. So I think there's a lot of opportunity to sort of advocate, like the university to advocate with the Royal College to sort of change their policies as well, because there are huge barriers to sort of managing this.
Yes, absolutely. And I think that's a good example of sort of ground up and that it's going to disseminate. Shirin, do you have any thoughts about the training and regulation aspect?
Oh, absolutely. I have a perma smile on my face because I'm so happy to be here. And I'm just so happy that we're talking about this as a department and that people are engaging in it. But I think this is the first step. Like, it's honestly been 2 years, I think, in the making of emailing people and talking to people and trying to get people to engage in this topic. And like the fact that we're doing this with, 250 people in both departments is the first step. And I love the suggestions that are coming up about talking to the Royal College. There have certainly been movements at other universities to do the same. And some of the things the Royal College has done, to their credit, is they've taken away some of the requirements in terms of like the timing of your leave to your exam. But we also work with I talk a lot to the postgraduate association at the University of Toronto about like encouraging people actually to think about that when they're planning their leave, maybe taking a longer leave actually, so that they're coming back and taking their exam at the right time. And there are definitely a lot of different spheres to this advocacy that we could go through. And I'm just happy that we're all interested in it.
Okay, we'll take an online question from Rebecca Gladdy. Sylvia?
So Rebecca writes, thank you for this really important collaborative session. One item not discussed is how to allow for time away from research responsibilities. For example, I was off for 6 months with excellent clinical coverage, but had to work in my lab 1 day a week, starting 2 weeks after my son was born. How can we brainstorm around this reality?
Okay, simple. Shirin or Andrea?
Yeah, I'll start. I think so. I didn't focus on it too much, but this did come up at the leadership meeting, and we did have really good discussion around it. There's a bit more expansion in our document that we hope to circulate to everybody to read as well. But there's some talk about like mentorship and that concept of maybe pairing people with someone else, transitioning some of those projects so that there's someone else that's stepping into that research role while you're actually on leave. There were different brainstormed ideas that came up at that leadership meeting that are reflected in our document. And I didn't focus on it too much, but I hope to circulate so you can read through all of that.
Yeah, I'm not sure I have the best answer to this either. I've had a few mat leaves, and I think with my first one, I had sort of a colleague that sort of helped take over some of my research studies while I was off, so that it did allow for more of a leave. I would say the further you get into your career, it is a little bit harder. I just came back from a mat leave with twins, and I was actually back doing research like probably a month after delivery, just because I had so many trainees that were relying on me to get their projects done. So I do think that this is something that we do need to look at and explore a little bit further. I'm sorry, I don't have the right answer to it, but I think having some overlap, some mentorship, some people that can perhaps step in and take over some of those supervisory roles while you're off.
Okay, back to in-person, David Urbach, I think is next. Yeah,
Thank
go
you.
ahead.
I think one thing that we don't think a lot about that really is an important driver of a lot of these problems with respect to clinical commitments and being able to take breaks is the nature of physician practice in Canada and Ontario, and the fact that we're all highly independent. So most surgeons and probably a lot of OBGYNs fundamentally have an independent practice. They largely eat what they kill, they manage their own patients, they own referrals and their own patient care. There are models where people work better in collaborative teams, and I think a great model is the Department of Surgical Oncology in Ottawa, where there's really a lot of integration, shared practice, where people can clock in and clock out much easier because everybody is sharing the practice together. And I think this would be really helpful for a variety of different reasons, but I wonder if people can comment on the extent to which the independence of our practice is a driver of a lot of these problems, and to what extent moving towards team-based models of care in surgery could be helpful in addressing it.
Okay, we have a few respondents. Maybe Erin, you have a response to that? Yeah.
I was just going to add on to David's. I think that a lot of the issues are around sort of money, right? It's financial. And I think it's actually very difficult to ask other colleagues to take out of their money to pay for other people's maternity leave. That's an issue. And so I think that we should also lobby the government. The government pays us, and we should lobby the government for them to provide money to sort of pay for maternity leave and parental leave, and and support us, and even health benefits. So I think that's another, I think the government should be helping to pay for this, and there should be additional funds for this, not coming off the backs of sort of other colleagues and our clinical salaries.
Okay, Andrea, do you have?
I just wanted to add to that. So I think that, yes, it can seem hard to ask for people within a group to pay for somebody else's leave. But I think if we frame this as a larger issue, that a lot of people might have to take unplanned leave for various reasons. You might have a sick parent that you have to stop working to look after. You may injure yourself at work. And there might be times that we all need to take unplanned leave. So maybe framing this as a larger issue that everybody could benefit from in times where they need it. But I do agree with lobbying to get more funds from the top as well.
I'm sorry, I don't know your name, but go ahead. Yeah.
Hi, I'm Olga. I'm new to the Department of OBGYN here, but I just actually wanted to share my experience coming from Queens, where they do have an alternative funding plan. And I had my third child there as staff. And it doesn't solve all these problems, but certainly as a new staff taking parental leave, I had a fair good amount of financial support, although interestingly, they reduced it since then, and help with the clinical coverage. There's still culture support issues that keep going, but it was, I felt, a good model, and I was really pleased as staff to have that support.
Yeah, Shrin, go ahead.
I just wanted to comment on Dr. Urbach's comment about team-based care. I think that is something that has definitely come up in a lot of our discussions, including at the leadership level, about how we can potentially support people. Certainly, I don't have any of the answers, but it's a discussion. Some of the things that people talked about through the interviews was, like, for example, I think a very specialized hand surgeon talked about how they transferred some of their cases to another hand surgeon in the city. And so even like expanding some of our networks, like past our smaller groups of like very subspecialized people that can collaborate to cover people while they're off for kind of those sort of urgent cases, could be something that we think about collectively as a group.
We'll take an online question. Tim Van Meegen.
So the question is, has there been a consideration to make this funded leave available more generally rather than for parental leave, i.e. care for parents, sick partner, sabbatical, mental health breaks, etc.? That would also give a benefit to those who chose not to have children.
So I'm going to ask Danielle to respond to that, our sort of white paper policy.
Yeah. So when we did our Department of Surgery working group on practice plans, this was discussed extensively. I think sort of similar to Andrea and Sharon's point. I think this is about all types of leave, parental leave being one, but also sabbatical leave, medical leave, caregiver leave. I think like most of us will be in our work, in our, I guess, division departmental roles for our careers, which span, I don't know, 20 to 30 years, I guess, depending on when you finish training. And I think we have to take care of each other. And that was sort of highlighted that even the people who either are not going to have parental leave or have already taken parental leave prior to becoming faculty, there's still sort of other leaves that they may benefit from. For our Department of Surgery policy, I think the other real principle is that everyone sort of felt that each practice plan needed to be able to have flexibility. And so we didn't come out with sort of specific recommendations for funding, but in our working groups, there was definitely appetite amongst amongst participants.
Okay, I think Kelly, you had a question? Dr. Murphy? Yeah.
No question, just more of a comment about, you know, going back to research and productivity, et cetera. I think as leaders, you know, we also have to have compassion and understanding and support. It is very difficult to continue research productivity during leaves. And so I think it's also all of us trying to changing our mindset and expectations. So it has to come from above, as somebody said.
Extremely important consideration. You know, a lot of granting agency award applications will ask you, is there a reason why you had an interruption in your productivity? But then you never know, you know, what the fact that you confess you had an interruption, you never know what impact that has on their considerations or deliberations. And I think it is important for us as leaders to maybe slow down that, you know, trajectory and the milestones and realize that people are going to meet them at very different points during their early career. And we don't have to be rigid. There's no need to say, if you haven't done something X by, 3 years, that's it, you're out, you're worthless. There just is no need for that kind of approach. Selena, you had another.
I was just going to follow on that. I think it's, going back to wellness too, right? And that the more we all take care of each other, the better we all are. And particularly for a lot of my male colleagues, they have taken on, historically insufficient amount of time with their families, insufficient. I think that really needs to change. It should be an expectation. I don't want to see you in the hospital. I think they need to spend time.
Go ahead.
Yeah, I think that's such an excellent point. I think they mentioned that in the some of the quotes that were up there, saying that if male colleagues took a little bit more time, then that would sort of make it easier for the childbearing staff to actually take that time. My question, sorry, was whether you guys talked about return to work plans. I don't know if you mentioned that, but coming back, going from like 0 to 100, whether there's like a graduated, or if you have had any thoughts on that, a graduated return to work.
I think Danielle's going to handle it.
I think that's really important. And I think in Sharon's recommendations, like she really, I think flexibility is the biggest thing, and sort of working with whoever is taking the parental leave to find out, like it's going to be different for everyone. And as faculty, there are significant financial pressures. And some people may want to come back at 100%. Some people may want to gradually return to work. Some people may want to come back to part of their practice that's manageable and like fits within their childcare constraints. And so I think it's really imperative that sort of these conversations happen and that there's really flexibility to tailor return to work to individual circumstances. And I think like breastfeeding is important here as well.
Okay, the next in person is from Jim Rutka, our former chair of the Department of Surgery.
Yeah, thanks. I've really enjoyed the discussion, and of course, some points of historical perspective here that we had the practice plans develop as a necessity to handle the demands from the dean's office, because all of faculty at the University of Toronto must be part of a conforming practice plan. So when I took over as chair before Carol, the plans were in place. I was very happy if there was some income sharing going on, but then that quickly devolved to the point where I was willing to accept just some support of the academic mission, because there were, as you heard, 30 different practice plans, and it was very complicated. And so I felt there was a real need to look into this matter, and that's hence why you heard I appointed Terry Axelrod, and then with Danielle Bischof. Big thanks to them for taking this on. I looked under the hood and I thought, well, I'm towards the end of my term as chair. I'm hoping that we can make some ground here, and I'm just delighted to see the progress that you've made since this was initiated, and delighted to see the supports coming forward, sure enough, for the academic mission, but more importantly for the parental leave. And we didn't talk about sabbatical, but that's also, I think, a big part of this plan. But the question I really had was, great, Francis, what you've done. The supports are fantastic for parental leave. But for parents, I just wonder, is it enough, right? When you look at other industries, other communities, other groups that are getting parental leave, I just wonder if we're way out of window for this. And are there ways that we can make it better for parents taking leave? And so one mechanism, as you heard, was to get government involved, as Aaron said. But, in the absence of that, maybe think about the practice plans across the hospital, surgeons in chief, asking for support from each of the divisions in the hospital, a small amount, but adding it up, stockpiling it so that a good amount is available for each parental leave that takes place. So I don't know how satisfied or dissatisfied parents are with the leave number that you're talking about, but it would be nice if there was a little bit more to offer, I think, individuals compared to what we see in the communities.
I see Albaya Kulkarni taking notes. I think he's going to come to you for your contribution. Thanks, Jim. Okay, we're at time. There are many more questions online, and thank you for those of you online for submitting your comments and questions. We do have them, and what we're going to do is organize a sort of comment question sharing group with the presenters from today. So they'll have all of your comments, and there'll be some opportunity to exchange ideas online. Sylvia will look after that. So once again, I just want to thank everybody who presented today. It was a really fruitful discussion, and I think the watchword is flexibility, and we continue to evolve. So thank you all very much for being here. Have a good day.